4 mm are risk factor for lesion progression and subcondylar bone collapse. As indicated previously, BML is commonly associated with meniscal injury, extrusion or resection, in some cases showing overlap on imaging with degenerative osteoarthritis. Research has shown that abnormality in sung are quite different from those corresponding to secondary osteonecrosis, which is characterized by an internal signal similar to that of fat and delimited by a peripheral serpentinous line of granulation tissue. Therefore, secondary osteonecrosis exhibits a central area with low signal intensity on T1 weighted images and high signal intensity on T2 weighted images with saturation. When the bone edema does not extend into the subcondylar cortical bone, other diagnostic alterations should be considered because, as mentioned previously, failure of meniscus cartilage subcondylar bone unit occurs in subcondylar fracture. Although SUNG is not a very rare condition, few studies have analyzed its epidemiology. One study reported an incidence of 3.4% among patients older than 50 years and less than 9.4% among patients older than 65 years. Women are typically more affected, although in some studies that perform MRI, the incidence among men and women was similar. A higher incidence is also found among patients who are overweight and those with poor bone quality. Clinically, patients generally present with localized acute pain more often on the medial side of the knee without a previous history of trauma that might account for the symptoms. More recent studies found some important correlations between BME and pain progression in patients. Felson reported a significant correlation between BML and pain in patients with osteoarthritis. In that study, patients with pain had a 3.3-fold higher likelihood of having BME compared with patients with the same radiological degree of arthrosis but without pain. In another study, Felson found greater progression of articular space narrowing among patients with osteoarthritis and BML. The presence of BME in the medial and lateral knee compartments was associated with 6.5-fold and 7-fold greater probability, respectively, of osteoarthritis progression. In addition, Roemer detected a higher risk of cartilage loss and the articular surface in the presence of BML through MRI assessment over a 30-month period. Corroborating those findings, the likelihood of joint replacement and the need for total knee arthroplasty are higher among patients with BML. This correlation is even more significant in cases of global lesions affecting one full femoral condyle or tibial plateau, which are typical of insufficiency fracture. It's important to understand that current studies evaluating the clinical progression of BME do not have any division as to the different types or pattern of BME. Also, it is not yet clear in the literature the best nomenclature for the image alteration found in MRI with bone marrow edema, using different terms such as BME, BML, and insufficiency fracture, and there is no clear distinction about the true difference between terms. Therefore, it is difficult to correlate the clinical findings of the studies with a specific type of BME, such as failure due to insufficiency. Insufficiency fracture treatment may be surgical or non-surgical. Generally, surgery is the first choice for patients with large lesions, more than 5 square centimeters or more than 50% of the condyle, or the aforementioned risk factors on MRI. Conservative treatment is based on anti-inflammatory and analgesic used according to the patient's pain, combined with reduced load on the affected limb for 3 to 8 months according to the patient's symptoms and radiological findings. Two additional medications that have been suggested for BML treatment are prostacyclin and the bisphosphonates.
And this is a 54-year-old male with complaints of knee pain. There was no history of prior trauma, just hurt really bad. And he had this scan. This is done about 8 months ago. He had lots of marrow edema in the medial femoral condyle, and there was no collapse of the articular surface. You can see this little triangle here is the medial meniscus. It looked normal. And when we see things like this, typically they have a tear of the meniscus, and there's abnormal stress, and they get this stress reaction. But this patient did not have any trauma, and the meniscus looked completely normal. So this is a case of what we call spontaneous osteonecrosis. You can also have something called migratory osteoporosis, where you get big regions of marrow edema that start in one area and may shift to another area many months later. So it's one of those two things. And let me put up another view. This is very sensitive for any marrow changes. And here it is. So you can see how just light bulb bright the entire medial femoral condyle is. And so this is again about 7 or 8 months ago. Now we're going to go to the new scan here in just a second. Now in the new scan, the marrow edema is still there, but it has improved significantly. Before it was really severe. Now it's just maybe moderate edema. We can see that the articular surface is a little irregular, but there's no collapse. So this looks like it is spontaneous osteonecrosis that has partially resolved, but not completely resolved. Again, they still have that abnormal signal beneath the cortex. So we're going to follow this in another few months and make sure that it continues to heal and this does not go on to collapse. His surgeon had told him that maybe they needed to do a knee replacement, but since it's getting so much better, we told him that he should hold off and just see if it completely resolves in another few months. Here it is on a sagittal view. Here's the medial femoral condyle. You can see here the darkness is the edema. You can see the cortex, the black line, is a little thick, and the cartilage over it looks normal. So that's a case of spontaneous osteonecrosis or migratory osteoporosis that is partially healed over the course of 7 or 8 months, but not healed completely.
Prostacyclin is a vasodilator. Its usage aims to improve the perfusion of tissues with impaired blood flow. It also reduces capillary permeability, inhibits platelet aggregation, and decreases free radical concentration. However, the mechanism that accounts for pain improvement in BML is unknown. Some studies demonstrated the efficacy of prostacyclin for BML treatment over a short follow-up period, with significant improvement in pain over the period of 3 to 6 months of follow-up. However, its results are poor in more advanced disease stages. The other drugs suggested for BML treatment are the bisphosphonates, a class of drugs that inhibit osteoclast activity, thus reducing bone resorption. Their usage aims to avoid the collapse of subchondral bone arising from the local bone resorption caused by the reaction to insufficiency fracture. Therefore, bisphosphonates may provide improved structural support until the local regeneration process creates a new bone structure sufficient to support load. The results of clinical study are controversial. Mayer did not observe significant differences between ivandronate and placebo in the only randomized double-blind clinical trial reported in the literature. However, Kranzlin in another study found clinical and radiological benefits with the use of this drug class. Lastlet tested the use of zoledronic acid for the treatment of BML in patients with osteoarthritis in the randomized clinical study. Pain improvement was observed in patients with medication with 6 months of follow-up, but not with 3 and 12 months of follow-up. No significant difference in knee injury and osteoarthritis outcome score was also observed. Regarding surgical treatment, cord compression is used for the treatment of BME located mainly in the hip. Studies have shown a reduction in the period of pain in patients with BME in the hip, but more benign and transient characteristics. Another surgical technique, subchondroplasty, is an option still in development albeit with promising initial results. This method stabilized microfractures affecting the subcondylar trabecular bone by filling the spaces between the trabeculae with a calcium phosphate-based bone substitute. Although initial studies demonstrated pain improvement and delay of total knee arthroplasty in some situations, the results cannot yet be generalized for all patients. The bone substitute used must possess certain characteristics for treatment to succeed. It must be injectable and capable of filling the spaces between trabeculae. It must exhibit an endothermic crystallization reaction to avoid overheating and necrosis of the local tissue. And it must have mechanical resistance similar to that of bone to support the local load without creating a locus of excessive pressure. In conclusion, there is still great controversy regarding the cause and clinical impact of BME images on MRI. However, it becomes increasingly clear the relevance of these alterations in image with correlation with pain and progression of joint degeneration. With this, different forms of treatment have been proposed with promising results. However, a more detailed study is still needed to better understand the patterns of bone edema to improve the knowledge of the natural history of each type of lesion and thus determine the indication of treatment. Thank you for your attention and thank you for your like, comment, and subscription.